Morning, good evening, good afternoon. I'm glad to be here. Thank you for the privilege to present at this wonderful conference of EQUINET, Reimagining Resources for Health. My name is Danny Gotto, and I'm the Executive Director of Innovations for Development. I'm going to present to you a paper that we wrote, research study that we did, examining development assistance for health and its role in sustaining health inequities. This research study was part of our project, which looked at examining colonial legacies in development assistance for health and the impact this has created on health sector financing. We based on the understanding of the problem that we continue to see that aid is increasing, or has been as at least going on, coming in, but inequities and inequalities in health have persisted, and they, come with different dimensions of history, gender, regional and ethnic perspectives throughout across the country. For example, when you look at poverty and malaria, on the right is the distribution of poverty, child poverty, and then poverty per capita. You can see if you compare with malaria, you can superimpose malaria endemicity onto the poverty. Areas that are poor are highly having high incidences of malaria, prevalence of malaria. So the study had a methodology where we reviewed literature through secondary data, actually, analyzing government, donor, agency reports, and so many other data sources that were relevant. We also conducted key informant interviews and a validation workshop where we engaged key sector experts to further digest the information that we had gathered. We, of course, our intention was to question the aid and how it manifests and who it focuses on and where and how in terms of geography and the like. So the findings revealed that aid is increasing for the last couple of years, about 10, 15 years. Uganda has been a very good recipient of aid. However, as that is happening, the health sector is continuing to have deficit, budgetary deficit, as allocation of government has not really significantly changed. Actually, it has nearly remained constant. So that is something to ponder about. As aid is coming in, government is not changing its investment. So the shortfall has remained. We are, from the data, we see that there are several bilateral agencies and multilateral agencies, but on the bilateral agencies, it is primarily the US government and the United Kingdom government and also many other European countries. And the focus is majorly health and the humanitarian space for the last 3 years, if you look back, 2018 to 2020. And also other areas like food and agriculture. Now, if you look critically here, you'll see other elements of social determinants of health, education, water and sanitation, social services, really receiving less as compared to health and the humanitarian assistance. That is very critical as an issue of equity. We are seeing that much of the aid coming in is primarily off budget, Actually, the current health expenditure of 41% from the aid space, only 21 is coming to the budget, national budget. And actually, when it comes, it is primarily focusing on procurement of HIV commodities. So the domestic and private health expenditure as a percentage of current health expenditure is 41. And much of it is out of pocket, and people are paying for malaria, NCDs, and some other non-infectious diseases. On the part of government only gives 17.2% of the current health expenditure, and much of it is wages and a little bit of capital development. So aid that is coming in, both for the budget support and off-budget support, is primarily focusing on HIV. So that is very critical in terms of the resources that leak out of the healthcare system, because as aid fails to invest in systems, there are loopholes. When we examine, for instance, several donors, but for this presentation I've highlighted USAID, we found out that there were a lot of inconsistencies in aid distribution geographically and the disease of focus. Of course, I've mentioned aid tends to cherry pick, and for the Americans, much of it is focusing on HIV. And UNICEF did a study in 2019 when they realized that about 5 districts in the country had HIV cases, but they did not have any investment from the Americans, from USAID. So that is really a form of inequity there, that people have HIV, and MACU government is really not investing in HIV because, of course, struggling with the illusion that the Americans are taking care of it. So we are seeing that neglected diseases, tropical diseases, especially non-communicable diseases, mental health, really suffering, and the people in there, especially those that are poor, are really doing badly when you look at the statistics on mental health and NCDs amongst the poor. So the aid is really also creating an illusion that government can borrow. After all, somebody else is looking at the bills. From the key informant interviews, somebody made a comment and said that aid tends to create a very high appetite for loans, for people to really try to, of course, development financing. And this has created a very high debt burden. 54.4% of the current debt burden, debt to GDP, is primarily the external debt loans. So to further look also into other aspects that aid has, created or distorted and created inequities, is the fact that it is short-term. It doesn't completely address the issues. It's mostly not accountable to communities. It's not sustainable. It is top-down. Participation of communities is very low. And of course, the evaluation bias tends to praise itself. So what are we doing? We are trying to work around shifting power, processes, and funds by ensuring that we deconstruct and dismantle the powers within aid, build local agency and capacity, ensure that the process is efficient and funding gets to the people. How are we doing it? We're building a coalition, local coalition, which is an assembly of local actors, CSOs, local NGOs, CBOs, all brought together, and we work to support them to come up with a broader understanding, but also getting to see that they work together. We build their capacity, we make them investment ready, and we try to work around convincing partners to work through them. because we believe that ownership is about working with those who are in proximity with the problem. They understand it better, and they are able to influence change. I would look forward to further converse around how the local coalition plays in terms of creating an enabling environment, but also investing in addressing inequities. I want to thank you.